The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everybody. Good day to you. And we're here for the next episode of TMD Demystified. I'm Tony Urbanek, and today the topic I've chosen is TMD versus dental symptoms. Actually, this is a very meaty topic. I think you're all going to be surprised about some of the things I say. Some of the things I'm going to say and talk about, I've touched on before, but we're going to go into a deeper dive on distinguishing between TMD and dental symptoms. And there's a lot of it going on, much more than you would think. And it's very important that you can differentiate the two. So after many years now, we're on year 11 since I initially made the discovery about the solution, non-surgical solution for TMD, which is get rid of the inflammation in the jaw joints. I have seen thousands of patients, upwards now of 5,000 consults. And it's the consults which really taught me 90% of what I have to say and what I know about this problem. Listening to the patients, I've said that many times before, but has given me a huge advantage to listen to that many stories, to listen to that many series of symptoms, mainly the stories on how the patients put it together and what the patients have gone through trying to get it fixed, and the many different kinds of doctors who have suggested and done this, that, and the other regarding their symptoms. And it's an ongoing process because we now are referred in here at my practice with Dr. Urbina and I in Middle Tennessee. We are referred in roughly 100 to 120 new TMD patients a month. So there's no lack of continued histories and stories and consultations that we do, and information piles up. But rarely nowadays do I see anything that I haven't heard before, a rendition of that heard before. But unfortunately, early on, I came across many cases of patients going to their dentist with what the patient thought was some kind of dental symptom, a dental symptom. Now, we've covered the ENT system, the ENT symptoms of tinnitus, subjective hearing loss, and vertigo that are extremely often confused. We've covered before the confusion of ear pain that ends up in the PCP or the walk-in clinic, or especially the ENT office, and they have ear pain and there's nothing wrong with the tympanic membrane. There's no infection. Sooner or later, somebody will say, no, there's no infection, but the first three doctors or nurse practitioners say, well, you must have an infection. Here's some antibiotic. But today we're going to concentrate on dental symptoms that are misdiagnosed, mistreated, misdirected, unfortunately, in some pretty serious ways. That's pretty common. This is not one-off. So the first I'd like to address is the confusion between TMD symptoms, TMD pain, and dental pain that the patient claims and swears is coming from their teeth. And here's the most common scenario that I hear from patients. They're having pain. It feels like it's coming from either an upper or a lower tooth. It can be either. I've seen it both ways. The patient says they can actually even point to the tooth and say, this tooth hurts. And again, it can be not anterior teeth, premolars and molars, most often molars, maxillary first, second, and third molars, if they still have their third molars erupted, and mandibular first, second, and third molars if the third molars are erupted. But most often, the first and second molar, and most often than that, the first molar. And they will go to a dentist and say, my tooth hurts. And the doctor admittedly takes an x-ray, does the little exam that we're all taught to do in dental school to distinguish whether the pulp is a problem, whether pulpitis is present. Several different ways to do that, but we all learned it in dental school, and nothing there. Nothing there. And the doctor says, on the x-ray, there's no decay, there's no periodontal problem. Doctor says, I see nothing wrong with your tooth or teeth. Sometimes it's several teeth. Patients don't like to hear that because they know that it's coming from the tooth. And I mean, I've had patients tell me in the rather lengthy history, I went to Dr. So-and-so, and I said, this tooth hurts, the tooth hurts. And the doctor examined me and said, no, there's nothing wrong with your tooth. Can't find anything wrong with your tooth. And that was it. That was the end of the story. He says, I don't know what to do. Unfortunately, on more than one occasion, I can't quote how many patients I've seen, but it's on definitely more than two hands that have talked the doctor or dentist into removing a tooth or two. And when they come in to see me, I know this happened. I get the history, and there's a couple teeth missing. That on one side, the contralateral side, the teeth on the contralateral side that were still present looked totally healthy. Bone was good, no significant decay, sometimes not even any restorations. But the tooth on the affected side, where the patient said they were having dental pain, the first and second molars are missing, sometimes a premolar, because they somehow talked the dentist into taking out a tooth that the dentist knew technically that there was nothing wrong with his tooth. That is in the minority. Fortunately for our profession, the majority of histories that I hear, the doctor just, I can't take out the tooth. I don't see anything wrong with it. That is the majority of the cases. But I have many, many cases that somehow the dentist decided, okay, I'm going to take out your teeth, even though I see nothing wrong with it. And then they come in here with a few missing teeth. And what they have is inflammation within the temporomandibular joint, which is easily diagnosed by doing that. And it's missed. It's misdiagnosed. And who knows where the patient goes next. And the patient keeps searching because they have this god-awful pain. And now the teeth are missing, and now they still have the god-awful pain. And because the patient says that's their only symptom, they didn't complain of headaches, they didn't complain of earaches, they may not have had headaches, they may not have had neck pain. Actually, many of them did. Many of those patients who had dental pain also, in fact, I can say this, all of the patients who complained primarily of dental pain also had several of the other symptoms, and the big four are headache, earache, jaw pain, and neck pain. But the questions weren't asked, and the doctor didn't even think about questioning about TMJ, because in most dental practices, doctors don't want anything to do with TMJ, and they don't know that doing that is an easy way to rule out or rule in inflammation of the temporomandibular joint, which is the definition of TMD, along with the symptoms. So I've made my point, and for those listening, I know, ladies and gentlemen, that you went to dental school and you learned how to diagnose a tooth. And when you see a tooth that you go, this is not a hot tooth, there's nothing wrong, this tooth should not be hurting. And I feel confident because I'm confident in my diagnostic abilities. Then obviously don't take out the tooth, no matter what the patient says. And obviously, one of the first things that you should think of not the last thing. One of the first things, if you have a symptomatic tooth that you can find nothing wrong in the posterior maxilla or mandible, do this and ask, do you have some of the symptoms? If you don't even remember the symptoms on the latter part of the list, if you just think of headache, earache, jaw pain, neck pain, if they have TMD, they're going to come up with one or more of those symptoms 90% of the time. It is so simple. So that's how you rule out dental pain as a pain that is not descript and you can't figure out what's going on and think TMD. The second part of this is three parts. The second part of this I want to discuss is the wisdom tooth, my own colleagues, my own situation. And I can remember as a young surgeon, I can remember many cases as a young surgeon, patients coming in and say, my wisdom teeth hurt. It's many years ago. And I did enjoy a long and very satisfying career doing major facial reconstruction and office surgery. And the hallmark of oral surgeon's office surgery always has, and hopefully always will be, taken out impacted wisdom teeth and now dental implants. Teeth and titanium seems to be the moniker of the day. But, you know, when I came up as a young doctor, was your income and your activity in the office was primarily impacted wisdom teeth. And I saw many patients who would come in of different ages and sometimes fairly young, sometimes in their late teens. And again, to remind you, this problem, TMD, is primarily a problem of females, 95% females, 95% females, because estrogen exacerbates inflammation. And whether it be male or female, patients would come in starting in their late teens, and the females do when they start the menstrual cycles is when the estrogen levels kick up. And it would come in and say, my wisdom teeth hurt. And I would look in their mouth and I'd look at the x-ray, and they would have 3/4 of the wisdom tooth formed, but it was fully embedded beneath the gingiva. It was impacted, the tooth was impacted, so there certainly was a reason to get the tooth out, but I saw no reason to have pain. And I can tell you now, looking back, I missed a whole lot of temporomandibular joint disorders because, and of course, at that time, I was geared to do surgery, including surgery of the temporomandibular joint, but I never thought about actually doing that little maneuver to see whether actually it was temporomandibular joint problems. Now that I'm enlightened, and for the past 11 years, when I was still doing office surgery, which I just pulled the plug on here recently, with the past 2 weeks, my duties have not allowed me to the point where I could do a whole lot of surgery. And finally, I pulled the plug and turn away any of our patient referrals that need extractions, impactions, and dental implants. But until I did that a couple of weeks ago, I routinely would see patients come in and they would have on x-ray impacted wisdom teeth, and they say, my wisdom teeth hurt. And I would look in their mouth, and there wasn't any inflammation associated with any of the 4 wisdom teeth that were impacted. Almost all of them were completely embedded below the gingiva. And I knew that a tooth that is not infected, not inflamed below the level of the gingiva, and if it's impacted, it has a need to come out, but it's not going to hurt. Now, all oral surgeons should know that, and all dentists should know that, but frankly, I think the general dental community doesn't understand that. If they see an impacted tooth, they immediately assume that it can be causing pain. Well, unless there's inflammation, there's not going to be pain. I mean, as you know, inflammation is one of the hallmarks, pain is one of the hallmarks of inflammation. Pain is one of the hallmarks of inflammation, along with swelling, along with redness, etc. So point 2 is directed directly to my oral and maxillofacial surgery colleagues. You have seen patients, if you have an active practice for any length of time, you have seen a bunch of patients who come in and they're complaining either with their parents or older patients past their teens and say, my wisdom teeth hurt. You look in their mouth and there's no reason, there's no inflammation around those wisdom teeth. There may be good reason to remove the wisdom teeth. But in any case, the doctor says, oh, well, we'll fix your pain, we'll take out the wisdom teeth. And of course, any oral surgeon, it says, see a set of impacted wisdom teeth, the first thing he's going to do is going to set them through the process. He's going to take them out. No problem with them taking them out, but telling the patient that it's going to correct their pain is not correct. And it's easy to distinguish between pain coming from the wisdom teeth. You do it the other way. If there's no inflammation, it's not going to pain. But if you're suspicious of temporomandibular joint symptoms, problems, all you have to do is open and close and push on the glenoid fossas. They close. And if it hurts, they have inflammation in the joint. And their pain is almost for sure. I mean, there's always an outlier, always some kind of outlier, but 99%, if they have hot joints and not hot wisdom teeth, their pain is coming from their joints for sure, 99% of the time. It's easy to distinguish. So directed to my dental colleagues or to my general dental colleagues who want to take out impacted wisdom teeth, which I wouldn't recommend as an oral surgeon, but you're welcome to. Don't take out wisdom teeth and tell the patient that it's going to take care of their pain if you actually know it's not. And if you don't do that and have a hot joint, you know it's coming from their temporomandibular joint. Treat their temporomandibular joint and take out their wisdom teeth. Take out their wisdom teeth. But don't tell them taking out their wisdom teeth is going to fix their pain, because they will be back in your office later on, a week or 2 or 3 or 4, or 2 months down the road, and they say, it's still hurting. Now what do? You told them that it was their wisdom teeth. Now they're still hurting. Now you boxed yourself in. So don't do that. Simple, simple. And the last point is directed to my orthodontic colleagues, because one of the primary symptoms that I hear, it's not high on the list, and actually it's not on the list that I generally use, but it is my teeth don't fit together evenly. My teeth have changed. My bite has changed. My teeth don't meet together evenly. It's come up as often now that I may want to add that to the list of primary symptoms, but it doesn't happen that often. Of the patients who have different types of locks, that is closed locks, that's a large group, and that's a very significant symptom. But of that subset of patients with various types of closed locks, inability to open beyond a certain amount, whether it be 20 millimeters or 30 millimeters, or patients who have intermittent locks, they go to open and they're held tight until the meniscus clicks back, and then they're able to open all the way. But any of those patients can complain of their teeth not fitting together. And what happens there, and the way I explain it to patients, and what is happening there for sure, without exception, is when the meniscus, which has been displaced and dislocated and come out in front of the glenoid fossa to a greater or lesser degree, but when it does come back, it doesn't come back straight in the exact position. It'll come back a little crooked, either like this or off to one side, one way or another. But when it does that, it takes up a little bit more room than it used to within the capsule of the glenoid fossa, and therefore it'll shift the entire mandible very slightly. But if it shifts it at all, it's going to take the entire mandible out of its centric occlusion, and the patient will say, my teeth don't meet together evenly. And it just started happening recently. And it's always associated with some kind of lock, some kind of history of lock, an old history or a new history, but it's always associated with some kind of history of lock. And of that subset, I hear roughly 5 to 10% of the patients, of the locking patients, will say, at times or constantly, my teeth don't meet together correctly. My teeth have shifted. And I don't know what's going on. And on occasion, they've already seen an orthodontist who may or may not pick up the diagnosis of TMD. Some of them do. And recently I had an orthodontist and that's pretty common. I have lots of experience with orthodontists telling patients with bona fide simple TMD that by putting them in the braces, putting them in orthodontic appliances was going to fix their TMD. Well, no, not necessarily. If you're lucky, 1 in 100. And if you do that, hopefully you will put the patient into centric relation, which equals centric occlusion, which I rarely see. I rarely see that. Unfortunately, I did a previous episode where I talked about what I've experienced with orthodontists fixing occlusion and ignoring the fact that there's a significant difference between CO and CR. But that's not my point here. My point here is when the orthodontist hears, or a patient comes in and says, my teeth don't fit together evenly, he examines the patient and he goes, for one reason or another, well, I can fix this. Okay. By moving your teeth around, well, that's going to compound the situation. And actually, I've seen a case of that. They had a joint problem, the mandible moved, and then the occlusion was adjusted to a new position with the meniscus out of position. And then we had a double whammy of trying to solve the problem, because now the jaw, which was in an inappropriate position, and the teeth were in inappropriate position. And when you got the jaw, the condyle, back into proper position in relationship with the meniscus, one way or another, now the teeth didn't fit together. And I've seen that, unfortunately. So that's why I named this segment, I named this episode TMD versus dental symptoms, not just dental pain, because teeth not fitting together is a dental symptom along with dental pain. So I bring that to the attention of those of you doing orthodontics. And again, distinguishing on the differential diagnosis, if you have a patient who comes in and says, all of a sudden, within the past 2 weeks or 2 months, 2 years, my teeth started shifting and they don't fit together anymore. One of the things you should do early on to think about and to do that maneuver. And if they have hot joints, you really need to treat the joint. And with the device tool, the urbanic device tool and protocol. That's what I recommend. It is what I recommend. And we have a long litany of patients with their own practice and now a growing list of network providers throughout the United States and Canada who are using the device and protocol to the benefit of their patients, the benefit of their practice, and the benefit of the profession. And it's growing. And what I have to say is very valid and now can be verified, say it again, by our recently released and completed independent study based on a total of 3,000 patients that were invited into the study. Everyone of those 3,000 subset was invited, and the ones that agreed to take the rather extensive long survey were a lesser number, but it was certainly properly organized and presented study independently done through Middle Tennessee State University, which substantiates all of my experience in the practice and experience of others. So that's what I have to cover today. I hope it's meaningful to each and every one of you, because if you are a dentist and you see patients in a chair, you will run into this. You will see this sooner or later. Maybe not as often as I see it, seeing 120 new TMD patients a month, but keep it in mind, you will see this. You will see patients who come in your office with dental symptoms, dental pain, tooth pain. Oh my God, my tooth hurts. My wisdom teeth hurt. And you look at the teeth and there's nothing wrong with it. Or my teeth don't fit together. Well, don't jump to the conclusion that the first thing to do is strap them up. You might want to consider doing this, getting a little history from the patient and considering if they have some of those other TMD symptoms. As always, I appreciate you watching. I appreciate your attention. I encourage you, invite you to, if you're new to this podcast, to go back and review some of the other episodes by title or by numbers. Start at number 1 and work to number 38. I think we're at number 38 now of episodes in TMD Demystified. I know there's a lot of really useful information about TMD that you can apply to your practice, whether or not you use the device and protocol that we use, which is patented and FDA approved. But it's really good advice that will help you in your understanding. Even if you don't treat TMD, even if you don't want to treat TMD, you need to understand it so that you can give your patients the best advice. You can lead your patients to good treatment, successful treatment. So for today, I encourage you to communicate with me if you'd like. I'm always available, as is our Director of Marketing and Education, Naomi Engelman. I can be reached at tony@tmjservices.net. Naomi can be reached at naomi@tmjservices.net, and our website, which I encourage you to look to, and which encourages you to become a network provider, is www.tmjservices.net. So for today, I hope you have a successful day or week, and I look forward to speaking with you as soon as possible, which will be our next episode in a week. Thank you.